And then for Katia and Maggie, how did you define how you're going to address the questions in person there?
So we'll do the questions at the end
Yeah.
in person with the participants here. We'll do
Mm-hmm.
that at
Yeah.
the very end after we log off.
Okay.
Some of them
Oh,
might
wait, after you log off?
yes, because
Okay.
some of them might get answered in the online session.
Okay. I can see we have some last minute people joining, so I'll just wait another minute or so.
Yep, that's fine. Got a very quiet room.
Pardon me?
Got a very quiet room. It's live on.
Yeah. What kind of setup do you have there?
We're in a room and we're in a pharmacy.
Oh, okay. It's a really interesting topic for me. I work for the BC Renal Agency, and of course, renal and diabetes are closely tied, and I know we implemented, for one of the locations, a foot care clinic, so it'd be good to hear some more information.
Yeah, that's good.
And just to let you know, once you start talking, I'll just mute my phone, but I'll still be on the line. So if you have any questions, it'll just take me a second to unmute it there.
Okay. That's okay.
I want to welcome everybody to the session. We're going to go ahead and get started. Just as a reminder, the right-hand side there's a chat box, and you can go ahead and talk amongst yourself, but that won't be moderated. To the left-hand side, we have a Q&A pod, so if you have any questions, feel free to ask them there, and then we'll answer them at the end of the session. Again, thanks everybody for joining us, and thank you so much. I'm presenting here Katia Langton and Maggie Stewart. They're here from Nanaimo, and we have a great presentation on foot care, a step towards good health. So you can go ahead and get started.
Okay, great. Thank you. So my name is Katia Langton, and I'm a certified pedorthist, and pedorthists are orthotic and footwear specialists. And we're trained in the assessment of lower limb and foot biomechanics for people with diabetes, arthritis, and painful foot conditions. And then we use orthotics and footwear to offload painful foot conditions, to protect. And our goal is to increase people's mobility and keep people active and moving, as well as protection.
Yes, and my name is Maggie Stewart, and I am a registered nurse specializing in foot care. And also, Katia and I both have additional training and certifications in lower extremity amputation prevention for diabetes in order to prevent foot complications.
So today what we're going to talk about is, these are the main objectives here of what we're going to talk about. But this is really geared towards type 2 diabetes, which is 95% of what we're dealing with. The other 5%, which is type 1 diabetes, we're going to be dealing with the uncontrolled type 1. And so that's really what we're going to focus on today. And so the first point is the burden and impact of diabetes. So diabetes is one of the most challenging health problems of the 21st century, and it has become a global epidemic, which we now define as a pandemic when it's global. And the diabetic foot complications are the most common and the most troublesome complication of type 2 diabetes. And it also
Katia?
leads, pardon me?
Sorry, do you mind just speaking up a little bit? The participants are having a hard time hearing.
Okay, so is this better?
Well, I'll just wait to see what they respond. But yeah, it does sound better on my end.
How about here? I thought I was going to speak too loud. Is that good?
Yeah, they said better.
Okay, so again, it's diabetic foot complications are the most common and troublesome complication of type 2 diabetes, and it leads to the greatest mortality and morbidity. Number 2, we'll talk about loss of protective sensation. So the blood sugars will damage the small blood vessels in the feet, and this in turn damages the small nerves in the feet. And then we start to lose the nerves that provide protective sensation to the feet. And now the foot is at risk of being injured. The next thing we'll talk about is ulcers and amputations. So the ulcers are one of the most serious complications as well that arise from the loss of protective sensation in the foot. And the ulcer is basically an open sore on the bottom of the foot, which is now an open pathway for bacteria. And now we can get an infection, and that may lead to an amputation. And so this is what we want to prevent. It's absolutely preventable. The loss of limbs is unnecessary, and this is why we're here.
Okay, and number 4, we're going to talk about nursing foot care. So these are just simple procedures that will support and monitor the diabetic foot and prevent foot complications. And if people are getting nursing foot care, it's wonderful because they usually see me on a regular basis, so I can really keep an eye on what's going on with the individual and any improvements or deterioration in the feet.
And number 5 here, we'll talk about offloading devices. So the first one we'll talk about is the healing half shoes. So we're going to see when you have an open wound on the bottom of the foot, if you put the patient in a healing half shoe that offloads and unweights that area, you absolutely allow the wound to close, and that's what we want to quickly happen. So that's the first one. The next one we'll talk about is diabetic orthotics, which are used on a preventative basis. And also, if there is a wound after it closes, we then use it to prevent reopening of that wound. And then we'll also talk about orthopedic footwear. So if we have loss of protective sensation with a foot deformity, like a bunion callus or heavy callusing, a bunion or a claw toe, now we want to put the foot into a shoe that has extra depth and extra width to house and support it. We'll be going through all of these.
So I want to talk about controllable risk factors. There are some risk factors for diabetes that we can't change. That includes aging, ethnic factors, and genetic factors. And these things do increase our risk of diabetes, but there's nothing that we can do about them. But we can control some of these other risk factors like obesity, diet, and a sedentary lifestyle. So let's just talk about these for a few minutes. The obesity epidemic is fueling the diabetes pandemic. In Canada, 1 in 3 adults are obese. Obesity raises their risk factors for developing diabetes by 2 to 4 times. So if you have a diet that's high in simple carbohydrates or processed foods and high sugar content, then this could certainly increase the risk of diabetes. And it's very obvious when we're looking at candy bars and sodas and using extra sugar in our tea and coffee. But because of our society today and the way that we shop for food, much of our food is processed. So there's a lot of hidden sugars that we don't even think about. There's sugars in our condiments. There's sugars in our yogurt, in our salad dressing. There's even sugar in crackers and peanut butter. So it's not the easiest thing to avoid. And because we're living in a more convenient lifestyle where things are more fast-paced and we just want to quickly run to the store, unless you're actually planning your diet, it's really, really difficult to stay from this high-carb, high-sugar lifestyle. And in addition to that, we all have gone more toward a sedentary lifestyle. And I'm speaking just simply about my children. For them, staying at home, watching TV, and playing video games is more of the norm. You don't really see a lot of kids out on the street playing hockey, playing ball, playing hide and seek. And when they do go outside, you almost have to define what play looks like. In fact, during the spring break, there was a commercial on the radio that was actually asking these kids, Well, these kids were going, well, Mom, Dad, what's outside? And it's like, well, that's the space between your home and school, and you can go outside, go for a walk and play, and maybe even climb a tree. So we're no longer farmers. We don't go out harvesting our foods. We don't go out to the well. And so our lack of exercise in our world is really, it's a huge change in our lifestyle. We now live in a world of convenience, of speed, and that just seems to be the style and how we live today. And unfortunately, it is contributing to a less healthy lifestyle.
And that's really well said, Maggie, because I've got to say, while I'm here, we picked up quick pizza for dinner tonight, and I'm sure that I'm here. My kids are inside, right? And so but we're talking about the consistent choices, not the choices that we make the odd time, right? The consistent choices is what's going to cause the biggest problems here. Okay, so we now have 9 million Canadians living with diabetes or prediabetes, and 50% of this population is unaware. So diabetes remains seriously underreported. And I just read another study that said for every 5 diagnosed patients, there are actually 4 that are undiagnosed and unaware. So it is increasing. And what's happening is the complications, the cardiovascular complications or the foot complications are starting to cause problems, and that actually sets the patient in motion to go into the medical doctor office and they end up getting the diagnosis, but the complications have already started to manifest. So now we're seeing with all this increase in people with diabetes, we're seeing that the landscape is absolutely peppered. Everybody seems to know somebody or a friend or a relative, and we can even, we even see in restaurants people that are testing their blood glucose in the restaurants at the table. It's just becoming very, very common. And we now have 1 in 4 Canadians have diabetes. And by the year 2020, in 6 years, it will actually be 1 in 3. So big, big numbers here.
So here's a list of some pretty serious complications that people can get with diabetes. However, the biggest complication is that half of the people with diabetes, unfortunately, are not diagnosed until they may have one of these serious problems, which starts the process of medical testing, and only then does the patient end up with this diagnosis. So the serious problem has had already a real head start. So these complications are often already progressing at the time of diagnosis. So examples are blindness, kidney failure, cardiovascular failure, and even erectile dysfunction, lower limb, foot, and toe amputations. So we're just going to focus today on foot care and preventing unnecessary amputations, but we just also want to bring it to the forefront that these chronic conditions can be prevented with some awareness, and that's why we're here today and we're having this discussion.
And what we're here to talk about is that amputations can happen. This is a very real complication with diabetes. And so no one thinks it's going to happen to them. And guess what? It can. And it is scary, and one or more of your toes could be at risk, and then your foot, and it's a progression, and it travels upwards. And so we want to catch this. People are surprised that actually something as simple as a small open wound in the foot could lead to this, but it does. And so, you know what, this is avoidable. This is preventable. That's why we're here today. We need to prevent the preventable every single time. And the amputations are actually up to 85% preventable, which is great. 85% preventable. So let's learn more here. How are we going to do that? So, because what happens is 70% of people with type 2 diabetes will lose some protective sensation within the first 5 years of diagnosis. And we know that some of these complications have already set in before diagnosis. So what happens is that, again, the blood sugars will damage the small blood vessels in the foot, and that in turn will damage the small nerves in the bottom of the foot, which provide protective sensation. And this is called neuropathy. And so it is quiet, but it's there. So the symptoms are numbing and tingling, sharp shooting pains going down the legs as the nerves are dying, and the sensation of bugs crawling. And you slowly lose the body's warning system that tells you if you're stepping on a glass or tack, and it tells you that you need to protect yourself. And so without this warning mechanism, you're susceptible to injuring your foot.
Yeah. I once had a patient who was walking around on laminate flooring, and he kept hearing this clicking noise as he was walking. And then he just kept walking around anyways in his bare feet, and then he noticed like a little bit of blood on the floor, and he couldn't figure out what was going on. And never mind that, he didn't know what this clicking sound was, and he looked on the bottom of his foot. He had no way of sensing anything at all, and he actually had a tack right through his foot that he couldn't feel. And it's someone that needs to wear shoes around the house. This is something that we talk about for protection. And the same person, too, had just had a bit of a slip down a last set of stairs. And then, again, there was a cut that ended up right underneath his big toe, and he didn't feel that at all either. And all he saw was the blood that followed behind. And this is how serious it can be with someone who he had absolutely no protective sensation at all.
Right, and it doesn't actually have to be a glass or tack that may injure the foot. Even normal walking can injure the foot. So when you don't have protective sensation or you've lost some of the protective sensation in the foot, simple walking will cause areas of high peak pressure. And so normally when you get areas of high peak pressure in the foot, the normal things that you'll do is, you'll get maybe some redness, but you'll get sore. And then you'll do the normal things to get off your feet, to rest, to change your footwear. But without this normal feedback mechanism, you can put task over body. So you can go and mow the lawn all day. You can get all that work done because you don't have anything to tell you to rest. And so then at the end of the day, you take off your shoe and you can have a blood-soaked shoe. You don't have that warning mechanism. There was actually a patient after Hurricane Katrina in Louisiana that fractured his big toe, and he said, I didn't do anything that could have caused that. And so with the questioning, it actually came out that he had helped to replace his son's baseboards after the floods. And so he'd been in that position, squatted down on his knees with his toe flexed for, 8 hours, fixing the baseboards. He had no idea. So you don't have that warning mechanism.
So this is a picture of two of our patients that we've seen recently. And the slide here reveals some peak pressure areas where calluses have formed. So you'll see calluses on both feet. So the one on the left side is just kind of below that fourth toe. And then the other one on the right-hand side is a little bit more spread out. But regardless, the cause of these calluses is the same for both of these patients. What's happening is that person has been walking around on their foot. They don't have the sensation of any pressure going on there, so the body wants to protect itself whenever there's pressure, and the body is going to form a callus. And this callus is going to continue to build up with the continued weight bearing, and eventually this callus can open up into an ulcer or what is called, or rather an open wound. And the reason for that is that the callus, it's hard on the outside, but on the inside it's actually pushing on the tissue and it's causing pressure in there, and eventually that can open up. It's kind of like the idea of having, if you had a rock taped to the bottom of your foot, and those of us with normal sensation would certainly be able to tell. But if you can't tell that rock's on the bottom of your foot, you're going to continually damage that foot. Even just walking around on it just for one day is going to create a big problem, and eventually there's going to be an indentation there. There's going to be injury to the foot and a potential for that skin to break down and open up. And then on top of that, because the person is diabetic as well, then the bacteria loves to feed on sugar, so it's very attracted to wanting to hang on into that wound, so it makes the healing very difficult. And we need to walk on our feet. So how are we going to heal this? This becomes very awkward and very difficult, because even just going to the bathroom and going to the bedroom or back into your kitchen again, you still need your feet to walk on. So this is a difficult process to try and heal a foot that has an open sore on the bottom.
So, and also what happens with the increased blood sugars, it actually causes a bit more of an arthritic foot. And so it decreases the ability of the foot to adapt to terrain. So instead of having a foot that will spread out pressures when you're walking, you've got a foot that can't spread out pressures as well. So again, you get that increased peak pressure. So again, it is like the perfect storm. You've got the loss of protective sensation, you've got the arthritic foot, the loss of the ability to spread out peak pressures, and the repeated forces coming down with this hard nodule callus. And then that can lead to ulceration.
So we know that up to 25% of those with type 2 diabetes could potentially develop a foot ulcer. The American Diabetic Association states that 50% of all unhealed diabetic ulcers result in death within 5 years. This is staggering, but it is preventable. Basically, a foot ulcer is an open sore on the bottom of the foot, and again, it's just a very awkward place to try and close a wound. And just simple walking is just going to increase problems with a wound on the bottom of the foot. So this coupled with the loss of protective sensation, and so you're not even realizing that that's becoming worse because you're not even feeling the pain. And this just happens by simple walking. My aunt has diabetes, and that's what spurred me on to wanting to get into foot care nursing. She's been a diabetic for a number of years and has some more chronic complications as a result. And she had a simple blister on her second toe, and she was walking on it for a while, knew that it was there, but she has no sensation at all on her feet. So what ended up happening is it did end up opening up. It did become a pretty bad infection to the point that that toe had to actually be amputated. So since then, she has been really paying more attention to her feet, wearing proper footwear, whether she's in the shower, in the house, or outdoors. So she's really paid attention to that now, which is really great, so that hopefully it's just going to end there and she's not going to have any further amputations.
And so at one point we did have a picture here of a foot with an open sore on the bottom. And as graphic as we've taken it out because it was a bit too graphic, but you know what we wanted to show is that as graphic as that was, you're actually lucky when you have that, because sometimes what happens with the loss of protective sensation, you're walking on the foot with the peak pressures, and the bones can actually fracture from the inside, but you don't know if you keep walking on it. So it actually, until that fracture opens up, sometimes this ends up being a blessing in disguise, because then the patient will go get some medical attention, and then we can start to heal and offload. And so it is a very awkward place to try to heal up a wound. It is the most common reason why wounds don't heal on the bottom of the foot is that continuous walking and pressure and continuous trauma. And so even when we see patients that are on bed rest, I mean, we visit them in the home, their bed rest is they don't leave the house, right? But they're still doing very many footsteps within the house, to the bathroom, to the kitchen, to the bedroom, and it's a huge number of footsteps in the house. So then that's where the healing shoe comes in, which we'll talk about. Now, 1 in 5 foot ulcers will lead to a lower extremity amputation, and half the people receiving a diabetic-related amputation will not be alive in 5 years. So these are staggering statistics. So really, we want prevention of the foot ulcers. It is a surprisingly high number, and actually it's only second to lung cancer, which has an 86% mortality rate. But the thing is, you don't just arrive at the doctor's office one day needing an amputation. It can be prevented. So we know that it can be prevented 85% of the time. We don't get to the point of crisis quietly. There are signs along the way. Again, it starts with the neuropathy, the numbing, the tingling, the sensation of bugs crawling in the feet, the lancinating, sharp shooting pains going down the legs. And at that point, proper education and assessment and testing must be done, and protection and offloading. And then, of course, the really necessary lifestyle changes to control the blood sugars, because the lower the blood sugars are, the less damage it is to the blood vessels and to the nerves.
So let's look at prevention. So how do we prevent this? So number one, we do foot screening. So this basically just involves an evaluation of the foot, checking for protective sensation. We do muscle testing. We check temperature, circulation, and assessing for both foot deformities and skin integrity. And what I mean by skin integrity is that we're looking at possibly blisters, possibly an infected ingrown nail, calluses, ulcers, corns. All of these things can contribute to becoming an open sore eventually. So we want to be dealing with those. Number two, the management of simple foot problems. So then basically this is what we do. We remove those calluses, we remove those corns, we help you with offloading, and we just want to minimize the foot trauma that's been going on that maybe you haven't been able to tell that's been happening because you've had a loss of protective sensation. So we're just having a really, really good assessment, a really good look at the foot and seeing how we can reduce those complications. Patient education. A little bit later on, I'll get into more depth, but basic patient education, like I talked to you about my aunt, wearing shoes around the house. One of my patients he walked around with a tack and then he cut his toe, and he still doesn't wear shoes around in his house. But this is something that would be really great if people could start thinking about this. Number four, we're going to be discussing orthotic shoes and diabetic orthotics, as well as the healing shoe and its role in offloading pressure and healing.
Okay, and so here we can see the monofilament testing. So this is the most important testing here. So this is a 5.07 monofilament exerting 10 grams of pressure. We literally push this into 10 areas in the foot. So one on the top of the foot, 9 areas on the bottom of the foot. And if the patient can't feel even 1 out of the 10 areas, it increases the risk of potential ulceration. So again, this should be done on actually done on a very routine basis with patients with diabetes, patients with pre-diabetes, with the elderly, with anyone complaining of symptoms of, numbing, tingling, bug crawling, all that stuff. And so it should be done regularly by the healthcare providers, the pedorthist, foot care nurse, the medical doctors, whoever's seeing the patient on a regular basis. And then based on the outcome of the test, it should actually be redone. If they can't feel even 1 area in their foot, it should be redone within 6 months. If they have some loss of protective sensation, coupled with a foot deformity, so that can be heavy callousing, that can be claw toes, bunions, a number of different foot deformities, then it should actually get tested every 3 months. And when was the last time that you have had this tested by a healthcare provider? Last time you took off your shoes and had your foot checked with the monofilament? And do you know your current level of protective sensation? So this is so important.
So let's look at management of simple foot problems. So because I am a foot care nurse who has some additional training in foot care maintenance, I'm just going to talk to you a little bit about what I do. So this is a patient of ours who you can see on the left-hand side of the screen, you can actually see the callus. And then with a Dremel tool that I use, I reduce that callus. So on the right-hand side, now that callus is gone. If you look closely at the picture of the foot, you can actually see an indentation where that callus was causing pressure on the tissues on the foot, which is a potential avenue for ulceration to happen. So this has to be removed, and if it continues to occur over and over again, then we need to look at some kind of offloading shoe and some way to reduce that pressure from happening on this individual's foot. We want to keep them walking, we want to keep them active, and we want to keep them mobile. So when we look at the examples here of some of our clients, so this particular woman here, she does have a loss of protective sensation. So when this does build up for her, she doesn't really feel it and she can't tell. And then she has a hard time even bending down to even look at the bottom of her feet. So I take pictures of her feet on my phone so then she in turn can see what's going on the bottom of her feet, just so that it helps to increase her awareness as well. So again, having a callus like this form is no different than having a rock attached to the bottom of your foot. And this needs to come off, just like that rock needs to come off from the bottom of your foot. Sometimes we have to use some softening agents. Keeping the foot well moisturized is a really good idea as well. And so basically what this is, a callus is just basically a toughened area of the skin that's become thick and hard as a result of repeated pressure and just by simple walking. It doesn't take much for these calluses to build up. So with patient education, I usually spend about a half an hour at a visit when I am doing foot care with a patient. So I can re-emphasize these points. And these are just some basic ideas for people to keep their foot in good maintenance. So checking your shoes before putting them on. And that might seem really simple, but I often picture like the grandfather or the grandmother going to visit their grandchild in their home. And kids are always into all kinds of crazy things. And who knows, one of those kids might put a little piece of Lego in your shoe just for fun, not even thinking about it. But even a tiny piece of Lego can actually put a lot of pressure on the feet over time. I know the other day I had a couple of tiny pebbles in my shoe, and I went out for a walk, and it was really annoying. And that was someone like me who's very used to feeling, and my feet are fine. I can feel. But the person that can't feel, it wouldn't take long before you're starting to put pressure on that foot and causing some damage. And because the sensation in the foot might not be so great, and with calluses sometimes even if you do have some sensation, the callus actually reduces that level of sensation as well. So we want you to check the bath water with your hands and not with your feet before you get into the tub. And then changing your shoes daily. So if nothing else, if you're changing your shoes daily, then you're changing the pressures that are going on in the feet, and then you're evening things out a little bit more. So that's a huge help if you can think about doing that. Washing the feet daily allows you to take a look at the foot, making sure there's no infectious processes going on, making sure there's no redness. So it just kind of makes you aware that this is something that you should be paying attention to. And then with regards to soap, we just suggest that you stay away from anything perfumed. Often people have conditions where they're very sensitive to this on their skin. Another patient of mine is very sensitive to soaps, and then she starts to scratch and itch, and it doesn't take very long before just with her nails in the middle of the night she's opening up a sore on her feet. So we want to stay away from anything that's going to be irritating on the skin. We want to keep the feet well moisturized with creams, but we want to avoid having any creams between the toes. Between the toes, we have some very, very thin skin. We don't want it to become moist in there. The toes are they're kind of close together anyways, as is, and we don't want that skin to break down because there's a bunch of moisture getting in there. So we want to keep that area nice and dry. And then the suggestion, too, never walk barefoot. If you're walking barefoot, you can't feel what you're walking on. You could potentially injure your foot without realizing it. Wearing shower shoes is great. Again, my aunt wears shower shoes. She also does aquasize lessons in a pool, so she wears her pool shoes as well. And she's very, very diligent about this. And I do believe that this happened as a result of that toe amputation, and she just wanted it to end there. So that's pretty great.
And so so when you were talking about the Lego, right, so there was a patient who, an older gentleman who was going fly fishing, and he pulled on his big fly fishing gum boots and did his fishing for a couple of hours, came out, pulled it off, and the boot was absolutely covered in blood. It wasn't he was doing some investigation, it wasn't his foot that was cut up. There was actually a frog had gotten into his gum boots, and he hadn't checked before he put them on, and it was, of course, the frog no more. So, but if it was a piece of Lego, it would have absolutely cut up the foot.
Mm-hmm.
So now we're going to, we can see these are the healing offloading shoes. So you can see they're half shoes. So the shoe on the left, you can see that there's no forefoot here, so or the front of the foot. All the weight bearing is taking place on the heel. So if we have an open wound or an open ulcer, an open sore on the forefoot, you can see when you're walking with these healing shoes, it's going to unweight the forefoot and allow that to heal. And again, that's the most common reason why wounds don't heal, is repeated walking and trauma. And then the shoe on the right, you can see the heel is not there. All the weight bearing is taking place on the front of the foot, the midfoot and the forefoot, and now it allows the heel wound to close up. And can you imagine trying to close that wound without a healing shoe? It's pretty tricky here.
Mm-hmm.
So we know that the mortality rate for an unhealed diabetic ulcer is ridiculously high, approaching 50%. So the goal is to close up these wounds really quickly.
Mm-hmm. So although these may appear awkward, this is the answer to your problem: temporary and affordable offloading to heal the wounds on your feet. So if you can imagine trying to walk on an open sore on the bottom of your foot and normal runners every day, it's not going to heal. This is going to be a very, very difficult thing to heal. So having a shoe like this is a good way to assist with that offloading.
And so now these are diabetic accommodative soft orthotics. So they're total contact orthotics. So basically, these, when the patient has a loss of protective sensation and needs some protection, they can't feel. When we cast the foot, so we take an impression of the foot and we create a device that hugs all the contours of the foot, what happens is the high peak pressure areas, it dissipates peak pressure, and the low pressure areas, it engages it. So it essentially makes the whole foot a weight-bearing surface. So it functions as a mini snowshoe. So now it doesn't allow peak pressure to develop. It will decrease that callus formation, which is the body's ability to protect over those peak pressure areas. And then you don't go through the whole cascade of events to callus, to which may open up in an ulcer. So these are soft. They're actually 3 layers, and each layer of foam is a little bit denser, each second and third level, a little bit denser than the layer above. So again, it slowly dissipates peak pressures and spreads out forces. Now, they are an investment. They're worth the investment. This is very different than off-the-shelf inserts that you can buy at a store, because those are function like a pillow. So those are great, except we don't want a pillow because we're not trying to just give comfort. We're trying to protect. So to protect, we want a total contact device that is soft. We don't want a rigid device. And so here we can see this is diabetic orthopedic footwear. So from the slide before, the total contact custom device is great if you've just lost protective sensation. In the foot exam, if you have lost protective sensation, but you also have a foot deformity, again, the heavy callousing, the claw toes, the bunions, and there's so many others, then you need a shoe that gives you extra space. So these have an extra 3/16 of an inch depth, right, to house the diabetic orthotic. It has extra depth to house the claw toes, the bunions. It gives space. And it also has extra width because we don't want that downward pressure on the forefoot, which is going to increase peak pressures. We want to protect. They'll be made of soft moldable leathers that will mold around the foot deformity so it doesn't cause an ulceration on the sides, especially over the bunions. And they will be customizable in order to, you can customize in order to increase stability and to increase mobility. And these ones actually have a built-in rocker. And so the rocker is really important. So in the medical device, the rocker is really important because it literally rocks you from heel to toe. So when we have a painful area on the foot or we have an area where we can't feel and it's developing peak pressures, we literally want to rock right over it to decrease the pressures. And so this is very different from the rockers that you'll see in the stores, the soft rockers. Those ones are there to create an instability to tone your buttocks. Well, we don't really care about buttock toning at this point. We just want to protect. So these are going to provide some protection here, which is when you have loss of protection, a foot deformity, these are what is going to help you here.
So do you take your shoes off at your doctor's office? And has your doctor ever examined protective sensation in your feet? Do you know as of today what your level of sensitivity in your feet is? Our studies are showing that this is not happening on a regular basis. So we're recommending that all people at risk take their shoes and socks off at their doctor's offices and request a foot examination with a monofilament. As we mentioned earlier, monofilament testing is highly predictive for potential ulceration, and we do this on a regular basis with our patients. With proper preventable measures, 85% of these amputations can be avoided.
And so diabetes is a global pandemic, and these amputations are a huge consequence. So you need to protect your feet. You need to be your own best healthcare advocate and fight for your health. No one else is going to do this for you. You need to own this. If you take control of your body and you fight for your health, then you will be able to stay active and mobile and enjoy a long life. This is the answer. You educate yourself and you fight to keep your feet healthy. You have the opportunity to have a long and healthy life. Your feet are not inconsequential. They are irreplaceable. And so we thank you for attending today. We hope you learned a lot from this presentation, and we look forward to taking questions.
Great, thank you so much for that. So I've been scanning through the questions, and we have a lot of good questions here. And some of them you've already answered in the presentation, but I'll still ask them, and then you can maybe summarize it. Okay. So the first question is from Howard. How do diabetics prevent toe amputations?
So with the prevention of toe amputations, what's key is to make sure that the person is checking their feet on a regular basis. And if they're having a hard time bending down to actually look on the bottom of their feet, they can actually have a mirror on the floor and look at their feet that way. Or the other choice is to have a family member take a look at their feet and give them some idea if there's extra redness in a certain area, or if they're noticing a blister or any kind of areas that look like they're getting increased pressure.
Great.
Yeah, and sort of with the whole presentation, we covered that. So the loss of protective sensation, the check-in, and then the assessments, the regular assessments, and then the protection.
Okay, great. I'm trying to see if I can bunch the questions kind of together. Another just follow-up. Do you recommend wearing diabetic socks? If so, how often should you wear them?
So basically a diabetic sock is what we're looking at when we're talking about a diabetic sock as a sock that isn't too tight on the feet and it doesn't have any seams in it. So a person that has a loss of protective sensation, if there is a seam in the sock that can actually put pressure on the foot, and I've actually seen this on people's feet. Some people also have swelling, and you'll see the seam of the sock there. So a diabetic sock is a good thing to wear on a regular basis, and it can help, but also it just takes, if you can even find perhaps an off-the-shelf sock that is loose, that doesn't have any seams in it. So like a seamless sock that can be worn so that that person doesn't have any pressure. So that's the idea, is to reduce that pressure that could potentially be happening with that sock.
Okay, great. And just for everybody listening, if all the questions that I'm answering or asking, they're all questions that are typed in the QA pod. So if you have any questions, feel free to just type them in, and then I'll ask them to the presenters here. Question for Jerry. What's the difference between pedorthist and podiatrist?
Yeah, so that's a really good question. So as a pedorthist, and a lot of people haven't heard of a pedorthist before, but basically we're orthotic and footwear specialists, and then we assess diabetic, arthritic, functional foot problems, but really we're just using footwear and orthotics to keep people active, moving, and healthy. Whereas a podiatrist, they do surgery, and they still will do some orthotics, but they also can do ingrown toenails and minor surgery. They can remove bunions, and so they can do a lot more
more of an invasive procedure. They're even they're surgeons. So if my aunt actually, when she had her toe amputated, it was done by a podiatrist in his office. So so they do some minor surgical procedures as well.
Okay, great. And then speaking of that, a question from Mary, where do we obtain these offloading devices?
From a healthcare professional. Now, if we're talking about, so offloading devices can be the healing shoe for open wounds, it can be the diabetic orthotic, it
Oh,
can
the
be the
footwear.
orthopedic shoes, so from your healthcare professional. So a pedorthist, so anybody that you're seeing on a regular basis that deals with this. Some of the wound care clinics will do this because they're usually what we say a lot of times it also takes a team, right? It takes a team to close the ulcers and to save a limb. So often there is groups of healthcare professionals working together, and it's wound healing and it will be offloading at the same time.
Okay, great. More in kind of the shoe realm. Question from Asoyus. What is a shower shoe?
Oh, a shower shoe. So, so my aunt that wears shower shoes and pool shoes, it basically looks like a neoprene boot, but the bottom of it is rubberized, so it's not slippery at all. So it's just got a rubber bottom to it, and it's an easy slip-on boot that can just go into the water, so it prevents her from sliding around in the pool and in the shower, and also reduces the potential for injury.
Okay. Question from Linda. I've heard that when the neuropathy reverses itself, it could be equally as painful.
Okay, so neuropathy is progressive, and it doesn't really reverse itself. It progresses. It will get worse. But it is a painful. It can be a painful process. So and everybody will present differently. So the numbing, the tingling, the sensations, and some people their chief complaints are the shooting pains going down the legs. And so it's actually they're getting symptoms like that. It actually does bring it to the forefront. So it's actually helpful in getting the diagnosis and getting some help.
Okay, great. A question from Brian. Is there any significance to an itch on the bottom of the foot from time to time?
Hard to know how to answer that question, but I don't. So what I would want to know is that happening on a regular basis in the same spot, and if it is there any wear down in the skin from that because that person is scratching a lot? Because I did have a patient of mine that kept scratching in the same spot all the time, and the doctor really wasn't sure why, but eventually it did open up because she actually didn't have the proper sensation to know that she was creating an open wound. So that should be something that should be looked at. It could be an allergic reaction. It could be symptoms of dry skin. It's hard to know what the cause of that is, but it should be looked at if it's a potential for an open wound to happen and if the person has some loss of protective sensation.
Okay, great.
And actually, maybe that patient or that person can tell us, have they had their sensation checked? Because with the loss, you can also get itchiness.
Yeah, great. I have the name down here, so I'll check for further comments below. Another one from Brian. He says, I downhill ski. Is there a potential for injury due to cold? Not frozen, but is cold a risk? Do I need boot warmers, electric? A number of my friends use them.
Okay, so if he has a loss of protective sensation, the boot warmers probably aren't a good idea because he won't be able to feel if it's causing, like if it's going to injure the tissues. And the cold, I mean, a lot of the patients, or a percentage, it's I think at least 25%, will also have some peripheral arterial disease. And so they will have cold feet. But it's actually pressure. So it's actually pressure is the biggest problem.
Okay.
So actually, if he does have a loss of protective sensation, and he does have, with or without a foot deformity, then it might be helpful to have a device in his ski boot.
Okay. The next one, is it recommended to use creams to avoid getting ulcers, or does that make it worse? And then just a general question about creams to use.
Okay, so as far as creams go, creams aren't going to hurt anything. What you don't want to do is put a cream on an open ulcer. but you want to be using that on a regular basis to keep the skin nice and dry and moist. I have a patient of mine that came to me with some pretty significant foot problems and callousing and so on, and his feet were extremely dry. And he's a guy, and he didn't want anything fancy, so I just recommended that he try some Vaseline with socks on over top at night, and he's been doing that on a regular basis now for a few months, and it's made a complete turnaround in his foot condition. It looks way better, way healthier, and that dryness is just gone. It's just made a tremendous difference for him.
But also, I think is he asking, will it prevent the callus from opening up into an ulcer? Because it's really pressure. Yeah, it's really, really pressure, and the cream alone isn't going to get rid of the callus. So it's really the pressure that we want to offload.
Okay. A question from Jerry here. Does lack of sensation in the feet cause balancing problems?
Yep, so absolutely. So if you can't feel areas of your feet, it's hard for you to orientate where you're putting your foot in space. You sort of lose proprioception. And so what happens is you tend to out-toe or out-toe your feet, so you're walking with a wider base of gait because then you think that that's going to help you and decrease the risk of falling. So what happens is when we have a patient with loss of protective sensation, when they're put in a device that's total contact, it actually increases the surface area of the foot. So the whole foot becomes a weight-bearing surface. So it can help, or it will help with, most likely, with balance. But of course there can be other reasons. There can be degeneration from the back causing balance problems. There can be all other reasons. So we're specifically dealing with the feet, but absolutely.
Okay, great. For Mary, where do we have this sort of testing done?
So so that's a good question. So it's really based on where you live, because again, we hope that everybody will go into their healthcare professional's office, take off their shoes, and ask for their monofilament testing. So we'd love it if it was straight across the board that all the healthcare professionals were using the monofilaments. They're cheap. They're $1. And it's really, really easy to do. And so it's really, we're raising awareness. But in the meantime, I would say foot care nurses, pedorthists, medical doctors, and you really have to be your own best advocate.
Okay. And then Catherine sort of has a similar question, which is how do I choose a foot care provider? Because besides going general.
Yeah, so we're looking, so there's, some people do go to the salon, and I'm just seeing the question here where they might see someone for a pedicure. So the thing with a salon is that it's not a medical person that is involved. But what people have to keep in mind is if they have a foot that has a lack of sensation, then they probably need to be having their foot care done with a healthcare provider, so possibly a foot care nurse. And the difference is that the foot care nurse isn't going to put on any kind of fancy nail polish, but they will be looking after your feet and dealing with important issues around infection, reducing your risk of ulceration, and doing a more thorough neurological testing on the foot to make sure that the sensation is still being maintained in the foot. So if you are diabetic and you have a loss of protective sensation, I would recommend that you find a foot care nurse as opposed to going for a pedicure in a salon.
Okay. And then kind of a second question she had would be the do's and don'ts of pedicures.
Okay, so again, so just kind of reiterating what I just said. So do's and don'ts of pedicure. So if you're seeing, again, someone in the salon, what you want to be leery of is, I know that it's really relaxing actually to be in a chair that's giving you a nice massage where you're putting your feet in a nice hot bath water with some bubbles. So again, they usually check the bath water, so they're good about that to make sure it's not too hot. So with some of these salons, you have to be careful in knowing how those tubs are cleaned. A lot of them have jets, and I don't know if they have any protocols for sterilization or cleaning of the tubs that people's feet are going into. So that would be a concern for me if I was going to go have a pedicure done, and certainly it should be a concern for anyone with diabetes that is more high risk for infection.
Okay, great. A question from Catherine. What role does athlete's foot or nail fungus play, especially in terms of moisture between the toes?
So with moisture between the toes, we want to try and avoid that at all costs. And I know sometimes with athlete's foot and nail fungus, then we see this happening a lot more, and you actually kind of see this flaking going on between the toes. And the best thing to do is to try and keep that moisture down between the toes. So even just using a towel, if they can bend down hopefully, and just drying up between each individual toe. I have someone actually that has this problem, and she has also her toes. They tend to be really squished together, so the moisture even builds up more. And what she does is she actually uses a cotton swab between her toes to keep her toes from becoming too moist in between, because you don't want that to be going on, because it is going to create more of a problem with the fungus and potential skin breakdown.
Okay, great. Another question, how often do you use diapazone for early detection of neuropathy?
We're not really familiar with the diapazone.
Okay. I'll see if any clarification. We can always come back to it.
Okay. Yeah.
Let's see here.
I see this question on Morton's toe.
Morton's toe, I've heard that there is a neuropathy related to this as well. How can it be differentiated with neuropathy related to diabetes?
Okay, so with Morton's toe, basically it's the second toe is longer than the first digit. And there's a reason, and you don't want that. So there's a reason that the big toe is nice and thick, and it's great for weight bearing, and you want to toe off on the big toe. And so if you've got the second digit is a bit longer, it turns into the primary weight bearing area for toe off. And so, but it's quite a bit smaller. So what happens is we develop a callus under the ball or of the second metatarsal head area, and it can become quite painful. So it's not really a neuropathy, but it's more biomechanical. And so really when we create a device, we modify it and we artificially extend the first big toe, and to pretend that it's longer, to turn it, to get it engaged and functioning again, and to offload the callus under the second digit. Does that make sense? Yeah.
Great. Question from Carmen here. Usually, how long after a person is diagnosed with diabetes does neuropathy happen?
So that's a really good question. So with neuropathy, I just read a study that 70% of patients will have some loss of protective sensation within the first 5 years of diagnosis. And then after 5 years, it's actually 100%. But it doesn't, it means some protective sensation. It doesn't mean the whole foot. Like people will have it in varying levels. And the key to remember here is it's based on the blood sugars. So the blood sugars will, in effect, nibble at the nerves, is basically what happens. So the more we control the blood sugars, the less effects on the nerves.
Okay. So I'm just going here. Are daily foot baths or using a wooden roller to exercise and relax your foot every day helpful for lessening the damage of neuropathy?
So the question here I just realized we have to cater to the audience too, but the question here is, are daily foot baths or using a wooden roller to exercise and relax your foot every day helpful for lessening the damage of neuropathy? So the important thing here is that the neuropathy is progressive and it's based on pressure. So it's a great thing to do to have a bath and roll your feet on the rollers, but it's not going to affect the progression, and it's really weight bearing. And so it's really pressure coming down.
Mm-hmm.
And if we were to get into physics, it's the pressure coming down and the body weight. And again, if we increase the surface area, we decrease the forces coming down.
Yeah, okay, yep. Great. I'm just popping over to the chat pod so I don't miss this one from George. What is the effect of alcohol on foot neuropathy?
So the question is, what is the effect of alcohol on foot neuropathy? So, and maybe we should talk about this here, but there's so very many reasons for neuropathy. So as well as diabetes, I mean, we see this in patients just aging and the nerves are dying, and drug toxicities and alcohol, and so many other problems. So, of course, the alcohol affects the blood sugars, and you can have neuropathy without being diabetic, but alcoholism. So it does progress it if you already have, it does make it worse.
I guess it factors, how often, amount, things like that as well.
See, but I can't even answer that because.
No, exactly, yeah.
Yeah, it's
a lot of different factors.
Yeah, that's a tricky question, but it's not. It is progressive.
Okay.
The more you keep it in check, the less the sugars and the alcohol will deplete the nerves.
Definitely.
My favorite saying.
A question from Barb here. What can be done about chronic ingrown toenails?
So with chronic ingrown toenails, sometimes this is something that's inherited, unfortunately, and it can be extremely uncomfortable. You can see a foot care nurse on a regular basis to have that ingrown toenail cut out or removed. If you want a permanent solution, you would have to go see a podiatrist, so a doctor who is allowed to do surgical procedure. And then what they actually do is they freeze the toe and they cut out that nail completely, either on that one side, or they can remove the nail entirely. And I know both young and old people that have had to have this done because it just chronically becomes infected and extremely painful. So if it's that bad, you might have to go see a podiatrist and go that route.
Okay. What would you recommend for patients with limited income to pay for offloading device?
So that's a really good question. The question is patients with limited income to pay for an offloading device. So with these offloading devices, this is private. So but there is coverage under Department of Veteran Affairs, Social Services, non-insured health benefits, and extended benefits, full coverage. And so people are often surprised that social assistance is fully covered, which is fantastic. So if you don't fall in those four categories, it is private. And so that's the thing. So in the States, this is all fully covered. Once a year with the it is all fully covered, but we don't have that coverage here for preventative. And it's very unfortunate. But the amputations are covered. We don't want to go there. So it's not a covered service. And we'd love to change that, and I don't know what the right answer is.
Perfect. Another question from Derek here. How informative are MDs with the assistance of pedorthists on the team, and how frequent are referrals made?
So that's a really good question with the MDs and the pedorthists. Just for my audience that's live here, how frequently are referrals made to pedorthists? Well, pedorthists are just getting recognized, and so we work with a group of medical doctors that do refer, but it's slow to get the word out there, to let everybody know what we do. And so I think that the pedorthic profession is growing, and so as the profession grows, they just become part of healthcare teams. And again, it would be great if there was more referrals, and we're hoping that that increases. But right now, it's probably pretty limited.
Mm-hmm. The next one from Ed here. What is the preferred lotion for cracked skin on heels?
Well, first of all, I wouldn't go with a lotion. Lotions have a lot of water content in them, so it's really important that you stay with creams. Creams are much more richer, and they are a better moisturizer for cracked heels. And a cream specifically with some urea and AHA in it is an extremely good moisturizer. And again, what's really important here is to be moisturizing on a regular basis. So if the heels are a problem and very, very dry, then this person should be moisturizing every day. And again, what I recommend is to put the cream on at night, and if you can tolerate just a loose sock on over top, then this is a great way to moisturize your feet and keep them well moisturized.
Mm-hmm. Okay, great. From Derek, and you've kind of covered a bit of this off, is it more efficient to seek assistance from a foot care nurse or a pedorthist, and what is the wait time in BC to gain access to either professional?
Okay, so I can't even see that question here, but I'm just going to repeat it it's somewhere here, but I can't see it.
Oh,
can you bring it up?
Okay, let's see.
Okay, so the question was, for our audience, is the wait time to see pedorthists and foot care nurses in BC, and it's pretty accessible because it's a very new profession. It's pretty accessible, and same with foot care nursing, so there's not a huge wait time.
Okay, and then is it more efficient to seek assistance from one or the other?
So
I guess,
generally,
equally.
So that's a good question. Is it better to see a foot care nurse or a pedorthist? We work together, and teams work together because it is the team approach. So with foot care nursing, they're removing corns, calluses, toenails, and all that good stuff that needs to happen. And then as the pedorthist, we do the offloading to prevent or to decrease the rate that the callus comes back, or to hopefully it doesn't come back, but sometimes it does, but just it works together hand in hand. So it depends what's going on. And then both will do the diabetic foot exam and the risk category assessment. And so it's basically a team approach.
Okay. One from Derek here. How long from the time of experiencing shooting pains, like a sharp needle, to more serious conditions like open sores?
Okay, so the question was how long from shooting pains, lancinating shooting pains going down the leg to an open sore? Well, the answer to that is hopefully never. Hopefully never, because again, if we spread out the peak pressures and we pick up the loss of protective sensation and we spread out the pressures, hopefully we'll never develop, well, we'll have a very small callus that will get removed regularly, right? And then the device, the custom device, will spread out the pressures, and then it will never open up. But it's only opening up because of the path, right? The pressures, the peak pressures, the loss of the perfect storm, the peak pressures, the loss of sensation, the callus trying the body's ability to try to protect itself, and then that hard nodule, toughened skin, pushing its way up into the foot, and then eventually it does open up. And once it does open up, we've got a big, big problem. And that's when we need to get it closed really, really quickly.
Yeah. We always, it's you've been mentioning really about the prevention and the identification.
So important, the prevention.
Question from Elaine. If you have gout, what can you do to help your feet?
With the gout, I do have some patients that have approached me with gout, and that's something that's going on more internally in the body, and that requires that person to actually seek some medical attention from their MD. And there are some medications that are available that can help with gout. And my understanding, too, is that even a change in diet can minimize and reduce gout. But I know it can be extremely painful and uncomfortable. And I believe that orthotics and some offloading shoes can also help with that, because I know that with gout, as a person walks, if they are doing a lot of walking, then the pain does increase.
Okay.
So I see a question here from Ron. Can we answer that one, Ron Semkow?
From Ron? Sure, let me find. I have a long list of questions here.
That's a very good question.
Ron, nail fungus?
No, so Ron has asked, is there any way of reversing neuropathy? I was given foot exercises using devices, rollers to stimulate the feet with no results, various natural health supplements, and then I can't read the rest.
I think that was at the top there.
So can we answer that one?
Yeah, you can go ahead and grab that one.
Yeah, so neuropathy is progressive. It's not reversible. And again, the foot exercises to stimulate the feet, that's not going to make any difference. So it is controlling. If it is a diabetic neuropathy, remember there's all different reasons for neuropathy, but if it is neuropathy from diabetes, it's controlling the blood sugar and then attaining the level of sensation, and then based on that, it's pressure. Pressure equals pressure coming down over surface area. So if we increase the surface area, we decrease the pressure and the forces coming down. And so we prevent this. But the exercises, because what happens is we lose the protective sensation with the sensory nerves. But after that, we'll start to develop a motor neuropathy, which is the muscles. So we start to, and this is the bigger part of this presentation, but we do start to develop more of a deformed foot because we start to lose the small muscles in the foot, which also protect and spread out weight bearing. So, but you can't exercise that back. It is progressive, and you just have to work with it and protect as the foot takes on a different shape. You protect it in a shoe with more depth, with more space, so that there's nothing rubbing and decrease the risk of ulceration.
I have a follow-up to one of the earlier questions on diapazone. It's a scaled fork for early detection of neuropathy.
Oh, okay. So the tuning
and then
fork.
And then the question was, how often do you use it for early detection?
Okay, so apparently we don't use it. No. So basically, if it's another name for the tuning fork. So basically, so the bigger picture here is that it is loss of sensation, but it's also loss of vibration and position sense, and you can pick this up with having the patient close their eyes and bringing their big toe up and bringing it down and seeing if they can figure out how their toe is orientated in space, and then with the tuning fork to see if they can feel vibration or position sense. But actually, we don't do that. We use the simple monofilament. It costs $1, and it's affordable, and it's easily accessible. And on the back of the monofilament box, there's 10 areas that, even a spouse can do it. So it's really easy to teach.
Okay, great. A question from Carmen here. Are callus or corn pads that look like Band-Aids advisable for diabetics?
So what we have to be looking at here is that a callus or a corn is the cause of pressure that's going on in the foot. So what we want to do is minimize that callus and corn from forming. So that needs to be removed. By putting on a Band-Aid type or a corn pad is not going to really remove that pressure. So again, we're looking at perhaps a foot care nurse or somehow reducing that callus and corn from forming, so that, and then we have to look at the source. Why is this pressure happening? It's happening because of pressure and friction. So then we need to be looking at the person's lifestyle. Are they a jogger? Are they wearing tight shoes? Are they wearing, high-heeled shoes with really, really tight toes? So that footwear needs to get changed, because we can't really get rid of that just by putting on corn pads, and we don't want to be covering that up all the time, because then you're increasing moisture in there. You're potentially putting that person at risk for breaking down their skin. So what we want to do is completely get rid of that, so that person no longer has a corn or a callus to deal with.
Okay.
And so also what happens is the corns are on the top, the calluses are on the bottom, but as the foot deforms, you get a lot of this clawing of the toes. And then you develop these corns on the top of these clawed or hammer toes because it's putting pressure from the shoe. So if we can, the depth shoe will actually help with that, because it decreases the rubbing or the pressure from the top.
Okay. The next one here from Margaret. She suffered from a severe case of salutes on my tibia in March. The area on my tibia is still red and often itches very much. Is there a danger that I will flare up again?
So with someone with cellulitis, I have a client that had, or a patient that had cellulitis, and it was the result of an ulcer actually that had opened up on the bottom of her foot. And because she also has a lack of protective sensation, she's very high risk. And actually just recently, she had another sore that did open up as well. So if this person who is suffering from cellulitis on the tibia, I think that this person should be consulting with their medical doctor, find out why is this happening. I can't picture how there might be some pressures going on in that area, or is this person scratching, and as a result that area is opening up and that skin is opening up. Any kind of open area, even from scratching, because this is how my other patient ended up with her second bout of cellulitis. It was just simply from her scratching, and she wasn't even realize she was scratching. It was happening in the middle of the night, and because she couldn't even feel it on her feet, she woke up with an open wound on her foot, and then she continued to put creams and various things on her feet, and eventually it got to a point where she actually had to go in for some antibiotic therapy to help to clear it up. So it's something to keep an eye on, and it's something definitely that that this person should seek out some medical attention and see what's going on.
Okay, great. Question from Linda about acupuncture. Is it a good idea or not?
So for the acupuncture, is it a good idea for the neuropathy or for the diabetic foot? So I'm not clear on that, but so acupuncture works well for painful conditions, muscular, skeletal, organ problems, but what we're talking about here is offloading pressure and a progressive neuropathy. So it wouldn't be my first choice.
In this context,
Or
okay. Okay. Ed, is there any way to get rid of yellowish toenail fungus?
With yellowish toenail fungus, this is common. I see a lot of this, and it depends on what's going on with the person. There is a medication that can be prescribed by a person's medical doctor, but it does have a number of side effects. A lot of people can't tolerate it. It's very hard on the liver. But it is helpful for some people. So you can consult with your medical practitioner on that. There are some clinics that are available that actually do a form of laser therapy on the fungal nails. We don't have a clinic like that in the Nanaimo area. We are on Vancouver Island. I know that Victoria does have a clinic. It can be expensive, and they don't guarantee results. So I think it really depends on the individual as to whether or not that fungal nail can be totally cleared up. From my experience and the patients that I have seen, some people have had a temporary clearing of it, and other people have had no success with clearing on it. So there's not any one thing that I believe, based on what I've seen at this point, that can totally get rid of the fungal nail.
I'm just reading through these. Can loss of sensation be restored?
So, we come across this question a lot. So again, it is progressive. But what's interesting is when you do increase so it does progress. The neuropathy progresses. It's not reversed. But when we do increase the weight bearing, the surface area, it does. There is studies that show that it does help because now there's more of the foot has a weight-bearing surface. So because the peak pressure areas are spread out and the low pressure areas are engaged, there is some studies that show that the contact devices will help with that, but it won't be restored.
Okay, and then another, I guess, kind of similar one from Brian. He was talking about a hot tub and then using jets for a foot massage. So we talked about we're not going to, reverse anything, but could this be a benefit?
Yeah, I think having a hot tub and a little foot massage doesn't hurt anybody, and if it's soothing and it feels good, it's just like kind of having someone rub your back, or it's relaxing. It's not going to hurt anything, and it might ease that pain a little bit and make the person feel more comfortable. So there's that. pharmacist here.
Oh.
And I think with some people, naproxen is good, and it is a good alternative